Hello, I'm Sarah Horst. I'm a third-year gastroenterology fellow at Vanderbilt University. Today I'm going to be talking about my abstract, Biologic and Immunomodulator Therapy Improves Depressive Symptoms in Subjects with Inflammatory Bowel Disease. Depression is often comorbid in patients with inflammatory bowel disease. Levels of depression can be reliably evaluated in clinic settings using a validated questionnaire called the Patient Health Questionnaire, or PHQ-9. A score of greater than or equal to 10 has been found to be sensitive and specific for risk of major depression. The aims of our study were to determine if depressive symptoms improve with medical treatment of IBD and if this improvement is independent of disease activity. This is a retrospective cohort of consecutive patients with IBD seen at a single-center tertiary care IBD clinic between October 2009 and June 2010. Subjects had new initiation of a biologic and/or immunomodulator or the addition of an immunomodulator therapy only. Measures that were evaluated included health-related quality of life using the SIBD-Q. Disease activity was evaluated using the Harvey-Bradshaw Index for Crohn's disease or the Simple Clinical Colitis Disease Activity Index for UC. Depressive symptoms were evaluated using the PHQ-9. 55 patients with Crohn's disease and 16 patients with ulcerative colitis were included in the study. Age and gender in the two groups were similar, as was follow-up with a median of 60 days. The majority of patients were started on a biologic plus or minus an immunomodulator. Prior to therapy in all subjects, 44% had risk for major depression or PHQ-9 scores greater than or equal to 10, compared to only 14% after treatment, a significant decrease. PHQ-9 scores decreased significantly after medication initiation in both the Crohn's disease and UC subjects. Disease activity and health-related quality of life scores also changed significantly. We then attempted to evaluate the correlation of the change between depression scores and disease activity and health-related quality of life scores. This graph shows the PHQ-9 score change on the y-axis for subjects with Crohn's disease after medication initiation. The disease activity score change is on the x-axis. As you can see, after medication initiation, the majority of the score changes on the PHQ-9 were negative, indicating improvement in depressive symptoms. The correlation of change in depressive symptoms and disease activity was determined by linear regression seen in the red line, with the confidence intervals in the gray areas surrounding the line. There was poor correlation, with the R-squared being less than 0.2. Similarly, there was poor correlation between depression score changes and health-related quality of life score changes in Crohn's disease patients, with the R-squared again being less than 0.2. These results may indicate that for patients with Crohn's disease, improvement in depression with the initiation of a biologic or immunomodulator may not be explained only by improvement in disease activity symptoms or quality of life improvements. In evaluating patients with ulcerative colitis, we found a moderate correlation of change in the depressive symptoms and disease activity with an R-squared of 0.6. Similarly, there was more correlation of change in the depressive symptoms and quality of life with an R-squared of 0.4. In these subjects with ulcerative colitis, the depression symptoms may be more related to disease state. In conclusion, these results indicate that depressive symptoms in IBD may improve with the initiation of a biologic or immunomodulator. In Crohn's disease, reduction in depressive symptoms was explained only in small part to improvements in disease activity and quality of life parameters. Further investigation into the mechanisms of depression in IBD is warranted. Thank you for listening to the discussion of our research. Any further inquiries into the details of the study can be directed to me at sarah.n.hurst@vanderbilt.edu. Thank you.